From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today we're talking about a randomized controlled trial of an innovative approach to treating chronic pain in people undergoing hemodialysis. So chronic pain is both common and particularly hard to treat in people on hemodialysis. And this study, which enrolled a geographically, racially, and ethnically diverse group of people from 16 sites across the United States, offers us insights into what might be accomplished with a cognitive behavioral approach to pain. So I'm looking forward to talking with our guest today. Dr. Laura Dember is a nephrologist and professor of medicine at the University of Pennsylvania Perelman School of Medicine. She's the first author of the paper, Pain Coping Skills Training for Patients Receiving Maintenance Hemodialysis. Welcome, Dr. Dember.
Thank you very much. It's a pleasure to be here.
Laura, in your study, you evaluate an approach to pain management called Pain Coping Skills Training. Could you give us a little background on chronic pain in people on hemodialysis and why you wanted to try out this particular approach?
Sure. So chronic pain is highly prevalent among people with kidney failure. Some studies suggest that about 60% of patients receiving dialysis have chronic pain, and it has a big impact on their activities and on their quality of life. And management of chronic pain is challenging in all patient populations, but it's particularly challenging in people with kidney failure for several reasons. One of these is that pharmacologic options for pain are more limited for people with kidney failure because of altered pharmacokinetic properties of many of the typical medications that are used for pain. Patients with kidney failure can be more sensitive to adverse effects of pharmacologic agents like sedating effects, for example. The toxicities of commonly used pain medications can be greater in the setting of kidney failure. Additionally, the types of pain and the causes of pain are pretty heterogeneous in people with kidney failure. And the tremendous burden of dialysis treatments themselves, the time that it takes to do dialysis, and the burden of comorbid medical conditions that are often present in people with kidney failure make it difficult to get pain care from pain clinics, for example, or usual settings where other patients can get care for chronic pain. Mm-hmm. So there's something very appealing about using a behavioral intervention in this patient population. And there's something very appealing about using a treatment that can be administered potentially, if the patient would like it to be, during dialysis treatments, where patients go 3 times a week. They spend, typically around 4 hours at a time at a dialysis unit for each session.
So it seems like that's a way of getting around some of the challenges that I think of in cognitive behavioral therapy, which is the time it takes, and you have to find someone who can actually do the treatment. And for many patients, it seems like that's much harder than just taking a pill to treat pain. But it sounds like you were able to find some way to actually make it feasible.
Yes, and I'll say a little bit more about that in a minute, but just to respond to your point about that it seems harder than taking a pill, which is sort of the way I might think about this as well. But patients with kidney failure getting dialysis are usually taking a huge number of pills. And for many patients, the last thing they want to do is take another pill. So what sounds like kind of an easy option may not feel like an easy option for this patient population.
Yeah, that's interesting.
So there actually can be a lot of appeal to a non-pharmacologic approach to treatment.
So tell me a little bit about what you actually did and what you found.
Yeah, so pain coping skills training, this general approach has been used in other patient populations, but we modified it for the hemodialysis patient population to address some of the things that accompany pain that are a little bit unique to this patient population, to address sleep disturbance, to address depression, things that accompany pain and maybe particularly prevalent in patients getting dialysis treatment. But the general idea of the treatment is that the goal is to increase self-efficacy on the part of patients and skills for coping with chronic pain. So the idea was not to address the intensity of their pain, but rather to help them cope better with chronic pain. And so the intervention consisted of 2 parts. The first 12 weeks were weekly one-on-one sessions with a coach that each lasted about 45 minutes. And these sessions were delivered by video conferencing, and they used cognitive behavioral training approaches and some motivational interviewing to, as I said before, increase self-efficacy and skills for coping with chronic pain. This second 12 weeks was a more novel component that was designed to help participants maintain the skills that they learned during the first 12 weeks. So this component consisted of automated daily 5-minute interactive voice response sessions that were delivered by telephone with asynchronous feedback that got incorporated once a week by the same coach that they'd been working with during the 12 weeks of the weekly coach-led sessions. And this interactive voice response system also provided participants, they answered questions using their keypad on their phone, and the answers to those questions helped the coach customize the feedback that the participant would get the following week. But the IVR interactive voice response system also provided participants with access to kind of skills refresher materials that they had sort of learned about during their initial 12 weeks, and then they could access as they wished during this second 12 weeks. So it was a 24-week intervention. First 12 weeks were weekly, 45-minute sessions with a coach delivered via telehealth, essentially video conferencing. And the second 12 weeks were these daily automated phone calls that they got, and they could accept or not accept as they chose, to help them maintain their skills.
And did it help in terms of you looked at something called pain interference. So maybe even tell us what that is and what the effect that you had on that was.
Yeah, so the primary outcome for the trial was pain interference, which means the extent to which pain interferes with activities, mood, and relationships. And we ascertained it using the Brief Pain Inventory Interference Subscale, which is a well-established instrument that is frequently used in pain trials. So that was our primary outcome. We had several patient-reported secondary outcomes like pain severity, depression, anxiety, quality of life, and pain catastrophizing. And then we had some clinical secondary outcomes as well: hospitalizations, falls, and death.
So sort of in a nutshell, what were your key findings?
We found that there was a statistically significant improvement in pain interference, the primary outcome. The reduction in pain interference was greater in the intervention group, pain coping skills training group, compared with the control group, which was usual clinical care. And this was evident at week 12 and at week 24. So at week 12, which was the end of the coach-led component of the intervention, and at week 24, which was the end of the daily interactive voice response component. At week 36, which was the final time point for ascertaining outcomes, which was 12 weeks after the intervention was over, the direction of the effect was the same. There was more of an improvement in the intervention group than in the usual care group, but the effect was no longer statistically significant. We also did what's referred to as a responder analysis, where we looked at the proportion of participants in the two groups, the intervention group and the usual care group, that had what is considered to be a clinically meaningful improvement in pain interference or reduction in pain interference. And that's a threshold that's been established in other patient populations. And when we looked at the proportions, there were about 50.9, I think, % of people in the intervention group compared with 36.6% in the usual care group who had what is considered to be a clinically important improvement in pain interference. So that's, a 14% absolute difference between the groups. It's a 39% relative difference. And if you think about the number needed to treat, that gives a number needed to see benefit. That's a number needed to treat of 7. So we were pleased with those results.
Are there sort of next steps in this area that you're excited about? Are there things that you want to look at moving forward?
I think there were some important things that we learned from this trial. And one is that the intervention was highly acceptable to participants, at least the people who enrolled in the trial. And there was, very high adherence to the intervention, despite the fact that it took time and despite the fact that people had this pretty high burden of care related to their kidney disease and their dialysis and their comorbid medical conditions. Only, I think, 10, which is about 3% of the participants who were assigned to the intervention, asked to discontinue the intervention, so they stuck with it. And many participants chose to do these sessions during dialysis treatments. The way we implemented the intervention was that we had a centralized team of interventionists, the pain coping skills training coaches. We didn't need an individual coach at every dialysis unit. And, there were 16 centers enrolled, that enrolled participants in the trial, but the patients got treated at around 100 different dialysis units. So if we had to have a pain coping skills training coach present at each facility, that would have been a no-starter. And so I think those are aspects that make me optimistic that this type of intervention could be scaled and could be applied outside of a trial setting. Mm-hmm. I think the next steps are that we need to do some work to figure out how to scale this up and how to implement this outside of a trial setting, because there were things about the trial that I think contributed to its success. We had a group of cognitive behavioral therapy experts who worked with the coaches to kind of standardize the approaches, to maximize the fidelity to the intervention, to work with them throughout the course of the trial to ensure that the intervention was administered as intended. So that's a potential challenge when thinking about scaling this and applying it outside of a trial setting. But centralized administration, ability to do this in a way that works for patients if they wanted to do it, if the trial participants wanted to do it during dialysis, they could. If they wanted to do it at home, they could. Making it work for them. Mm-hmm. These are all things that I think will help with post-trial implementation of this type of intervention.
Yeah, it seems like there was so much about the design of this that lends itself to being able to be scaled up in ways that are manageable for people. So it's exciting to think about this as a new approach that actually could be accessible to people and usable to people sort of, as you said, outside of the trial setting, but in a broader way.
And one of the things I didn't mention earlier that I think also contributed to the success of the intervention is we had a group of patients who served as advisors to the investigator team, and they were involved from the very start when we designed the protocol, when we designed the intervention, when we created recruitment materials, and their contributions, I think, were key to making sure the intervention that we were evaluating was something that was acceptable to patients, was felt by patients to be important, that it really resonated with patients. And that is something that I've done little bits of with clinical trials in the past, but this was the first trial where that patient involvement has been as extensive as it was. And I'm now a true believer in making that part of all intervention trials.
That's fantastic. And that's such an important point. And I think that's a really great place to end on, which is the value of participatory research and of involvement by the people who are going to benefit or not benefit from the results of the trial in the design of it. So thank you so much for joining us today. I'm Dr. Eve Rittenberg. I've been speaking with Dr. Laura Dember about a cognitive behavioral approach to pain management in patients receiving hemodialysis. You can find a link to the article we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.